Here's exactly what happens when my patients say they are ready for their epidural, if they want one, of course. Number one, I give them a bolus of fluid. If my patient consents and it's appropriate for their situation, I oftentimes give a dose of IV fluid pretty quickly, because one very common side effect of the medication given through the epidural is hypotension, which means very low blood pressure. One of the ways we try to offset this potential side effect is by raising the blood pressure a little bit by giving that additional fluid. This is so case by case. There are some patients where it is not safe to give them additional fluid or elevate their blood pressure, but for many people, this may be something that they suggest. Number two, I help my patient get up to the bathroom. Fluid is usually still running. My patient's using the bathroom, and I like to go to the bed, change the sheets, freshen up the pads. When an epidural is placed well and working well, most people are not going to have any sensation from the upper mid-abdomen down to their feet, which means getting up out of the bed to the bathroom is usually not safe. I like to have my patients empty their bladder one more time if they're up for it, so when the epidural is placed, we are starting with a fresh, empty bladder. Number three, I help them back to the side of the bed, and if they're okay with it, I apply a blood pressure cuff to their arm. Usually on the other hand, I place a pulse ox sticker, which is a little sticker that has a glowing red light to tell me what your oxygen and heart rate level are. And then me and my patient, and if they have a visitor, we all put on surgical caps to keep our hair tied back. Where I work, the visitor is allowed to stay at the bedside during the placement of the epidural, so the visitor and I will then put on a surgical mask. Number four, if my patient is not already on monitoring, I ask my patient if we can place continuous fetal monitoring. The medication given through the epidural to help relieve that pain so well has side effects, risks, benefits, like every medication. We want to make sure that baby is stable and responding well to this new medication. Number five, the anesthesiologist or the CRNA coming into the room, and they're bringing with them a huge anesthesia cart on wheels, and it has everything they need to safely place this epidural. Number six, I ask my patient to get into a position that's going to make the placement of the epidural a little bit easier. In most cases, my patient will actually be sitting upright. I actually ask my patient to do terrible posture, like an angry Halloween cat or a shrimp. Rounded and hunched like this, and the goal is for the bottom of the back to really sort of poke out. When we lean that lower back forward, it opens up the vertebrae and makes it easier for them to access that space and get you your epidural. Number six, just had a coughing fit. Where I work, partners are allowed to be present during the epidural placement, so I usually bring a chair or a stool right next to my patient, have the partner sit down, and they can support, hold hands. I'm right there with my patient too. I offer whatever level of support they need. Finally, number seven, where I work, we do something called a timeout, and it sounds a little something like this. Are you ready for a timeout? We have Jane Doe, born this day. She's getting an epidural placed. She signed the consent. They're on the chart. Jane, do you understand the epidural placement? Do you have any questions? Do you have any concerns? Do you agree to have this procedure? Final safety checks to make sure that we're all on the same page. For more information on pregnancy, birth, postpartum babies, give me a follow. Check out my page.